Issues at Hand, powered by
Protea Hotel by Marriott Entebbe. Comfort and luxury at its best.
Welcome to Issues at Hand here on Church of Uganda Family TV with me, Adrian Austin Mukalazi. It's a pleasure having you tuned in. Of course, the issue at hand today, we want to look at HIV/AIDS. Now, we know that every 1st of December is World AIDS Day. And here in Uganda, as per Uganda AIDS Commission, we believe that by 2030, we shall have an AIDS-free Uganda. That is about 5 years from now, and we are yet to know how that will be achieved and what that really means. But also, it should be remembered that it's now over 40 years ever since the first case of an HIV AIDS patient was diagnosed here in Uganda. And of course, in one of the places of Kasensero and Lukunya, I was interacting with a few people, and they told me that the truth is the first patient was coming from this place, but we never learned out of this. That message really meant a lot, especially when it gets to awareness. But we want to talk about the prevalence of HIV AIDS in Uganda currently, and what are the available preventive measures, of course, as we look into the bigger vision of 2030. With us is Mr. Assimwe, Stephen, from Uganda AIDS Commission. It's a pleasure having you this morning.
Thank you.
Good morning.
Good morning to you.
Kindly greet our viewers, and then we get into our discussion today.
Yeah, good morning, everyone.
Mr. Assimwe, of recent, the Uganda AIDS Commission came out with a fact sheet of the prevalence of HIV AIDS countrywide. And of course, you presented a few statistics and categorized in a way that I would like you to break them for us to understand them, because it was even more scaring, especially when the chairperson said that the prevalence among the newborns is even very high. That was even more scaring, that up to now we still really have this prevalence coming up and up. Yet, our vision is coming closer and closer. The deadline is coming closer and closer. But to start with the prevalence, according to the fact sheet that was presented by the Uganda AIDS Commission of recent.
So the prevalence at the national level is 5.1%. Okay. So that is the general population prevalence. That means if you randomly tested 100 people, without any subgrouping, then you would get 5 out of every 100 turning out HIV positive. And that is progress, because when the HIV epidemic first came in Uganda, prevalence was always estimated in higher numbers, 18% in some areas. And so that reduction to 5% is progress, but the challenge, like you said, is that there are disparities within the populations. So if you go a little bit down into the detail, there will be some subpopulations with higher prevalences. So the disparity, in fact, begins with gender, because if you break down the population into males and females, then for females, the prevalence is 6.6%, and for males, it is 3.6%. So almost half the prevalence between men and women. And then the other disparities can be geographic. So if you go in some areas, you'll find some local governments with higher estimated prevalences. And then if you go into certain specific populations, so if you think, for example, female sex workers, those will have a higher prevalence. And there are other subpopulations, people in fishing communities, and other different risk groups. So yes, there has been progress, but like you have said, there are disparities within specific groups and geographic areas.
Okay. You talked about sex workers, you talked about people
Fishing villages.
Fishing villages, and are there any other most at risk communities as per the prevalence?
Other most at risk communities. So you would have sex workers, people who inject drugs and maybe otherwise use drugs. So, and if you break that one down, so the women who inject drugs will have a higher prevalence, and the men who have men who use drugs will also have who inject drugs will also have a higher prevalence, lower than the women in the same group, but still much higher than the general population.
Okay, that is good news. Especially, it is a message of hope. But are you convinced that at least there is now awareness, so we no longer have people who still think that HIV/AIDS is witchcraft or a misfortune?
Yeah, I think at that level, yes, we have probably overcome that. The myths are not as bad as that. So yes, there is some awareness, but also we have been concerned that there has been a dampening down of maybe the response, because when HIV first came, many of the people who lived through the earlier AIDS epidemic were more aware and more concerned about maybe HIV prevention. So now, with the different interventions, the picture of HIV and AIDS has somewhat changed. So I think in some places people have said there is complacency, like people thinking that HIV is no longer such a big problem. So at that level, yes, there is a problem. But in terms of information, I think people have a substantial amount of information. So there would be very few people now who think that AIDS is some kind of witchcraft, as opposed to a disease that should be dealt with.
Yeah. We also look at people who have normalized living with HIV. For instance, among the young ladies, especially the adolescents, so those that where they fear pregnancy more than HIV. Is this a threat to your cause as Uganda AIDS Commission? Where people have normalized living with HIV and they think it is something normal to live with, so you no longer have to worry about it, but rather you worry more about the pregnancy.
You know, it's a hard question. I think it has two levels. First of all, we encourage positive living. So if someone is tested HIV and they test HIV positive, our message today is that that is not a death sentence anymore, and there are interventions that can ensure that people who test HIV positive have good, productive lives. They can live normal, healthy lives and access treatment and become healthy. So to that extent, it is good that people can see that message, and because of that, you then reduce the stigma and discrimination. Because if someone is HIV positive, they can do their work normally, they can live like any other member of the society. So that is one side to it. But the other side to it, of course, is that then some people will feel like, if I get HIV, I will take my medicines and I will be okay. But the president himself, in fact, has argued that, and he has even asked the scientists to give him proof that can you really say that a person with HIV is at the same level of health as a person without HIV? And as far as I know, the scientists have not provided to him like a contrary answer. So it would be that there are challenges and people should not simply say, oh, this is a normal thing. And you can actually get that well from speaking with persons with HIV. So if you speak to them, they will tell you different things. Medicines have side effects. So if you have to be taking medicines every day, that is not a situation that you'd like to be in. And several other challenges that you might not appreciate, but like a person living with HIV, if you sit them down, they will actually tell you, and you may not like it. Yeah. And so I think I have tried to answer your question by stating those two angles related to this. So my message would be that everybody should protect their health, not just from HIV, but from other things, because there is no saying that I would rather be unhealthy than healthy. Yeah.
We've also seen very many interventions where people come out and say, I prayed, or I was prayed for, and I got healed. We've also seen others selling herbals, saying if you're living with HIV, this herbal can substitute the ARVs that you've been taking. I mean, there are a lot of messages out there. What is your comment on that?
Again, that is another complicated question. Me, myself, much as you are calling me Mr. Assimwe, I'm a medical doctor. And so I will tend to come at problems like this from a biomedical perspective, where I think that it's a biomedical issue. We need biomedical solutions. And that is where now, for example, the drugs and treatments come in. So, of course, that is going to be my standard position. However, I don't want to discount the role of these other things. This being family TV, for example, you would know the importance of prayer. Yeah. So it does not necessarily mean that if I pray, the prayer will take away my disease or my health issue, but it has a role. So it has a role in terms of mental health. It has a role even maybe in terms of things we may not understand. And so my message would be that people should take, yes, the biomedical interventions, but certainly there is a place for other things, mental health, good nutrition, prayer, and so I think the challenge is someone thinking that only one thing will address my issue, whereas in many cases you would need to have like a more holistic view of these things. So for the herbal remedies, that one I would tell you that I don't know, because me again, I'm a researcher, so I would encourage like people who think they have a remedy that works to bring it up and test it like in more scientific ways than just, let's say, making a claim that this works. So it might work, but again, me as a scientist and maybe as a medical doctor, I will want some clear evidence that this most certainly works. So I can't dismiss it, but yes, I need evidence that it works.
Okay. Talking about the prevalence, what are some of the interventions, especially by the Uganda AIDS Commission, that are out there and supporting, especially in the management of the virus and the disease?
So when you think about interventions, I think for us now, we think more in terms of our broader national plan and national strategic plan, and it covers many things. So it would cover mostly 4 areas. So one would be prevention. So you would find some interventions towards preventing HIV and AIDS. Then there will be some care and treatment, meaning that people who are tested HIV positive, then they need to get some interventions to ensure that they are healthy, they have a good quality of life, and they can live long. So care and treatment, that would be like a second area where there are interventions. Then another area where there are interventions is social support. So I have already talked about like stigma and discrimination. All these are important. Like even if I am on my treatment, if I am being discriminated against, let's say someone is chasing me from work, maybe I can't access certain facilities, certain services. So all that affects health. And so there are interventions in social support, especially geared towards that of like reducing stigma and discrimination. And then there are also interventions in systems building, like building systems for health and making sure that even where you have interventions, there are systems to provide these interventions appropriately and ensure that the people that those interventions are targeting can access them and use them well. So those are the general areas where there would be interventions and investments by not just us as Uganda AIDS Commission, but by different partners. So Ministry of Health, the donor groups. So for example, the PEPFAR, I think you may already know about PEPFAR. And there's also the Global Fund, which is like a big program also to address HIV, and not just HIV, but also TB and malaria. And all those groups are making investments in these different areas. So now maybe back to the more specific parts of your question.
Yes.
If you are thinking about prevention, what we encourage now is known as a combination approach, where like people use different things to protect themselves. So an example could be that there are things in the biomedical realm, like how I had already mentioned. So an example there could be something like condoms. But then there are also things in the social behavioral realm. So an example there could be abstinence for young people. It could be faithfulness for married people and maybe people in stable relationships, and the other things that you can think of as social behavioral interventions. But they are even at a higher level, like a structural, what you can think of as a structural level, where maybe us as Uganda AIDS Commission or the Ministry of Health will put some policies in place, kind of create a better environment for service delivery, policies against stigma and discrimination. So those will also be contributing to the prevention. Then for care and treatment, I think the major intervention there now is again the antiretrovirals. So these drugs, tablets, and more recently the injections that people take. And I think one challenge there is that we need to expand this beyond just the antiretroviral therapy and start thinking about other things that contribute to people's health. So like nutrition, like maybe a good environment and other aspects, mental health, all these things that are important to maintaining people's health. So that I think that is like a brief mention, but also to say that these interventions, as USC, we coordinate the program, but certainly there are many partners that are implementing interventions in these areas, starting with us, then the Ministry of Health, and all these other the government system, for example, where you would have the regional referrals and the district hospitals, but then also now the not-for-profit institutions, the different NGOs that are working in the HIV space, like TASO and MJAP and several others.
You talked about some of the preventive measures, and we've of late heard about the injection, but we've also heard about PEP and PrEP, and sometimes people don't even know what these terms mean. When do you qualify to get PEP? When do you take PrEP? When do you take the injection? And how does this injection works? I mean, I request that you give us a little more knowledge about this.
Okay, so what you have said is the biomedicals, and these are the the things that are used for prevention within that domain of the biomedical interventions. So I can mention them maybe one by one, how you mentioned them. So starting with PEP. PEP stands for post-exposure prophylaxis. So that means someone has been exposed to a risky event, and to minimize their risk, there are some studies that have suggested that if you take a certain combination of these medicines, you have reduced your risk of turning out HIV positive later. And so the target group for this would be, when PEP first came, its primary target were the medical people, especially the ones that are working in surgical areas, where they would be maybe like suturing people and they prick themselves. So that is an example. And so if they felt that this was a high-risk exposure, then they would take those drugs. More recently, there are thoughts about, for example, people who get raped. So as a victim of rape might then be at risk, and giving them these drugs could be an intervention to reduce that risk. And maybe I have given those two examples for PEP. PrEP is a different kind of intervention that stands for pre-exposure prophylaxis. Again, it is studies suggesting that if people that are at a baseline, how can I say it, a high baseline risk. Like there are people, let's say, if I was a sex worker and every day I am getting exposed multiple times to a certain risk, then you might say this is a candidate for giving this intervention that says before I get exposed, if this intervention can reduce my risk, then I could use it. So that is PrEP. You can imagine the target group for such an intervention would be people that are already at a high risk, maybe based on what they do, usually that. So that is PrEP. And then the other thing you mentioned is injections versus tablets. So over time, normally the delivery of these medicines changes. So when both PEP and PrEP, even the antiretrovirals, now the medicines that people take daily just as treatment for HIV, when all these first came, they were tablets. And initially they would be high pill burden. We call it high pill burden, like every day someone could be taking maybe 10 plus tablets. So as the interventions improve over time, that reduced to maybe like 1 tablet a day. I think maybe that is the best they have now in terms of tablets. But then also some injectables, let me just call them injectables. Some injectables also started coming up. I think the first one was an injection that acts over 2 to 3 months. So someone could take it, and for the next 2 months, they could be covered by that injection. The more recent one is up to 6 months. So someone could take an injection, and it is active for up to 6 months.
Of all these PrEP and ARVs?
So this is available only for PrEP and ARVs. So it is not available for PEP, because you see many of these things are guided by scientific studies. So if a scientific study has not tested this as a PEP intervention, then it will not be available as such. So they have tested it as the usual ARVs. That is not yet happening here, but in some more developed countries, it is there. And then for PrEP, some of these studies for the injectables have occurred here. So there are people who have received these injections as part of their participation in the studies, and normally after the study has ended, they will continue receiving those injections as long as they are not negatively reacting to them. And I think some of the injections are now coming into the program where ordinary people would be able to to access them. So I think I have.
Should we say that for now in Uganda, especially, this program is not yet open
for
the
PrEP,
injectables?
I think for PrEP it is.
Okay.
For PrEP it is because the injection that lasts 2 to 3 months, I think that one is now available. It may not be available in every program, but to some extent now it is there.
Okay.
Yeah. And what is not yet available at program level but has been available at research level is the 6 months injection. Yeah.
Okay. That is also promising and giving hope. Now, having talked about these interventions, we realize that 6 years from now, we shall have reached the deadline that you promised us, that by 2030, as Uganda AIDS Commission, are you confident enough to still say that by 2030 there will be no more HIV tales?
Okay, I need to clarify first of all what we are talking about here.
Yes, so because that is end HIV by 2030, and when someone reads that hashtag, they think that there will be no more HIV.
Yes. So what we are talking about now is called the Presidential Fast Track Initiative to end AIDS as a public health threat in Uganda. So that is a loaded statement, and clearly you can see that there are some nuances there that we might need to clarify. Yeah. So I can begin with what does it mean. First of all, this was an initiative launched by His Excellency around 2017, and the goal is that to end AIDS as a public health threat by 2030. So the key words there are number 1, AIDS. Okay, so you will notice that that is slightly different from HIV.
Yes.
Because you have HIV, which is the thing that you go, you have a test, they'll tell you are HIV positive. But then you have AIDS, which is this constellation of diseases. Like you have someone with a depressed immunity, and then they have many diseases attacking them, and that is what we know as AIDS. So that is the first key word, that the goal is to end AIDS. So that's number 1. Number 2, as a public health threat. So meaning that you could still have some cases, but you are trying to ensure that our population is no longer threatened by this. And so it is more of that public health approach. So that is number 2. That is another key word. So end it as a public health threat. So now when you say HIV, I think the language should not be ending HIV. Because HIV, in my view, is like a more complex phenomenon. And what you see is AIDS. Even when, if you remember, maybe in your childhood and you were seeing people and they are saying this is an AIDS patient, yes. That is the picture that you want to deal with and end it. And so after 2030, you wake up tomorrow, it is 2031, then what do you expect? So you expect that some people could be HIV positive, but they are accessing treatment interventions and they are having good health. So that would be still an end of AIDS as a public health threat. So that is an example. So let's say you have a large number, actually, because if our interventions are working, then people are not dying. So you might have a large number of people that are HIV positive, but they are healthy. And so in terms of this PFTI, there are a few other things that we think should end. And one of them would be AIDS-related death. So you want that even if, let's say, you have people that are turning out HIV positive, you don't want people dying from the AIDS. And that is where you want like a target of 0. So that is one. Then number 2 is new HIV infections. So you want that you accelerate prevention interventions to such an extent that there are no more people being diagnosed as HIV positive. So if you did that, that would be an achievement. There would still be people that have tested HIV positive from below. But if again you have managed to reduce this to zero, that would be an achievement. Then the third one is stigma and discrimination, like having nobody being really harassed and harangued around because of an HIV positive test. So those are some of the goals of that PFTI. So are we confident that we shall get there? Yes, the time is short, but one thing that we have been talking about is accelerating interventions. So accelerating our response. Yes, we are responding. The time is short, but when you accelerate your interventions, you might be able to achieve some of these goals. So in November, on November 13, we have a meeting. It is called the National HIV and AIDS Symposium. And that meeting, the theme for that meeting is accelerating interventions to end AIDS by 2030. So that meeting is a national meeting. It will be at the Office of the President here in Kampala. There's that ministry building near Parliament. It has a big auditorium, and that is where the meeting will be. So you can see the theme of that meeting is accelerating interventions to end AIDS by 2030. So I can't tell you where we shall be like by 2030, but certainly there has been some progress. There are challenges and threats. When you look around, you see maybe in this area we are not doing well, but there will be a scientific meeting at that event which tries to look into such, to say what are the possible reasons why we might not, hit this target. So yes, I can't tell you like this is exactly where we will be. But I know there has been some progress, and two, if we are clear on these goals, some of these goals are achievable, and we know there are clear interventions to achieve this. And also there has been some good work that has been done, for example, in the area of stigma and discrimination. We know that has really substantially decreased. AIDS-related death has also substantially decreased, but is still unacceptably high. So even at that meeting which I mentioned, there will be an in-depth discussion of that subject of AIDS-related death. How can we completely eliminate this? And so, yeah, I have given you a long answer, but hopefully
indeed
you have picked.
Yeah, but it was actually relevant, and it was really important. Now, lastly, as we draw closer to the end of this discussion, we've had stories of places that are hard to reach, where sometimes patients miss out on their drugs, not because they do not want to be regular, but because sometimes there are delays in deliveries because the places they are at hard to reach places. Some of these places are islands or even landing sites, but they are hard to reach areas, and we've had such reports coming through and such stories coming through. But also you realize that in such places, you say that these are the most at risk, especially people who live in fishing communities. But also, you realize that the prevalence in such places is high, simply because there is, I could say, limited awareness or low awareness, especially about what we are talking about today. Are there any interventions to address such challenges?
Okay. I think maybe to answer your question, I'll begin with World AIDS Day. Because you had indicated earlier that you wanted me to say something about this year's World AIDS Day. So the interesting part about your question is that this year's World AIDS Day is in a hard-to-reach area. Okay. So it is in Buyende district. I think this is close to some of the fishing communities that you are talking about. So World AIDS Day is like it's a global event. Actually, it's an international event, but we commemorate it nationally here in Uganda every day. It is 1st December, and His Excellency is usually the chief guest almost every year. Like in the best of my memory, every year he's there. So I hope he will be there this year as well. And the theme for this year is a global theme, which is taking a rights path, and it talks about something like how can we ensure that the rights of people, now especially the people that you have talked about, most at risk, hard to reach, but they have a right to health, and so how can we ensure that their rights and their right to health can be ensured? So that will be the general theme of World AIDS Day. So and I think that is relevant because this venue now for World AIDS Day being close to fishing communities, so the issues affecting those populations and the hard to reach areas will be like a major focus of this event. So now going back to the real issue of now those hard to reach populations, how could we be reaching them better? So you have already mentioned awareness. So sometimes reaching people is not necessarily reaching them physically, but you may want to reach them with a message. So I think really the first thing that we should be thinking about is how can we reach these people with information about HIV, about AIDS, about health, and to make sure that within their environment they can be more healthy. So information and awareness, that is number one. Of course, increasing service delivery. Now, that is more of an area of the Ministry of Health and the local governments. They are the ones that are really doing everything possible to ensure that services get to the last mile. And the last mile is usually that hard to reach area. So yes, there are interventions that are meant to do that. One of them has to do with simplifying the interventions, so making them, simpler. If you think about HIV testing, with now testing moving into the self-testing realm, I have seen studies like in fishing communities where that self-testing approach is being embraced. Then I have also seen other approaches that you might think of as like peer-to-peer. So sometimes if there is a hard to reach area there, me as Dr. Assimwe, I might not reach there, but there could be a peer, like someone there. So within the Ministry of Health strategy, I think they have the community health workers, where within those hard to reach areas, you'll have a community member that is there, and that becomes an easier way to get the service to these people. Within the HIV program, the peer model is also emphasized, so that within the fishing communities, for example, you'll have some peer health workers, and within other high-risk populations. So yes, the peer-led model is another one. I talked about simplifying interventions. Of course, there are several partners that are doing outreaches. So outreaches, I think, is the oldest intervention in terms of trying to reach hard to reach areas. So those ones are still there, but now there are more, I think, innovations that